Hello. In this lecture, I will discuss image analysis techniques applied to neocortical epilepsy, focusing on cortical dysplasia. First, I will present a method to assist the visual detection that you will be using during the course and demonstrate its utility to transform MRI negative FCD to MRI positive FCD. In the second part of my talk, I will show you data on recent methods we have developed for a fully automated detection and biotyping of focal cortical dysplasia. As discussed in the lecture on visual diagnostics, FCD can be seen on MRI. Both FCD Type IIb and Type IIa generally present with increased cortical thickening, blurring of the gray-white transition, and intensity changes best seen on FLAIR as shown in these two cases. However, the MRI spectrum of FCD comprises variable degrees of gray matter and white matter changes, making the visual detection challenging, and as in these two examples, in whom blurring of the gray-white matter transition may be very subtle. These cases are typically referred to as MRI negative. Importantly, however, they are not negative. On the contrary, the lesion is there, but difficult to see. So, to enhance lesion visibility, we model the main features of focal cortical dysplasia type II using voxel-wise texture analysis of 3D T1 weighted MRI. In essence, we quantified gray matter thickness, blurring, and the gray-white matter interface and signal intensity. To model cortical thickening, each individual voxel was used as the starting point for gray matter run length coding, performed in each possible discrete direction as shown by the red arrows. To model the blurring between the gray matter and white matter, the absolute gradient of gray level intensities was calculated in a cube centered on each voxel. In the region of normal transition between gray matter and white matter, the gradient is expected to be steep. In regions of gray and white matter blurring, the gradient is less steep, thus blurring on the gradient map appears dark. To model the hyperintense signal associated with the lesion, we calculated the absolute difference between the intensity of a given voxel and the intensity and the boundary between the gray matter and white matter, defined using a histogram. Using the relative difference allows analysis of voxels located within the cortical gray matter in which the intensity is higher than normal and overlaps that of the white matter. Notably, a hyperintense FCD has intensity characteristics similar to the gray-white matter boundary and appear bright on the map. Integrating this method in the visual inspection, we were able to increase by about 30% our sensitivity from 50 to 87%, while maintaining more than 90% specificity. Here are two examples of subtle FCD lesions that were initially reported as MRI negative. However, as you can see, there is hyperintense signal on the relative intensity map and blurring of the gray-white matter interface appearing dark on the gradient map. And here are the lesions outlined on the T1 weighted MRI. So, by using texture analysis to assist visual inspection, we can transform MRI negative into MRI positive. Here is another example of a difficult to see case in whom the diagnosis of MRI negative epilepsy led us to miss the epileptic focus. So this was a 27-year-old male with epilepsy that started at 7 years of age. He had mainly nocturnal tonic posturing with arms dystonia followed by hypermotor features. There was no aura in these seizures. The MRI was initially reported as negative, and the patient underwent an SEEG investigation. The SEEG showed interictal spikes which were rare, more frontocentral than parietal and located on the left hemisphere. Ictally, he presented both diurnal and nocturnal events. The diurnal events were centrotemporal left, he had 2 of them, and most events were nocturnal with generalized onset, but more marked over the left side. And here are the preoperative T1 weighted MRI. You can take some time to look at it and to find a lesion in this patient. This is the MRI after the first operation. Unfortunately, the post-surgical outcome was unfavorable and the patient continued to have the same type of seizures. These are 2 adjacent axial T1 weighted MRI cuts and their corresponding texture maps. As you can see, there is a small region of hyperintensity and blurring in the posterior quadrant, and this is the lesion on the preoperative T1 weighted MRI that was initially missed. The patient was reoperated in this area and became seizure-free. These are again the other cuts where you can see the subtle lesion in the posterior quadrant. So you can examine how difficult it is to see the lesion, but how the texture analysis in fact assisted your diagnostic. Now moving on to another case of so-called MRI negative epilepsy, who had episode of status epilepticus with hypermotor features. When looking at the texture maps, we saw a subtle blurring with local signal breakdown on the gradient map and a signal intensity on the relative intensity map in the orbitofrontal region. This was very small, measuring 6 millimeters in diameter and with a volume of 260 cubic millimeter. This finding pushed us to go back to inspect even more carefully the MRI flare and T1 images, where you could confirm a subtle blurring in these areas. The FDG PET showed frontobasal hypometabolism in the same region, extending to the inferior frontal convexity. The patient was implanted. Interictal changes were characterized by polyspikes in the mid-contacts of the frontoorbital electrode, shown by these red dots. Ictal changes were seen over the same contacts. Clinically, seizures occurred in clusters with agitation, pedaling, and right arm dystonia, as well as dysphagia. The patient was operated and the histology sample showed FCD Type II. This is another case of so-called MRI negative epilepsy. I let you inspect the T1 weighted MRI and now the flare images. And here are the texture maps showing a large yet difficult to see region in the right orbital frontal with blurring. The blurring is present on the T1 MRI, but very subtle, as shown by this sagittal cut. So this case demonstrates again that what defines FCD visibility is the degree of severity of lesional features rather than size. In the second part of my talk, I will show you data on recent methods we have developed for a fully automated detection and biotyping of focal cortical dysplasia. As discussed in Neda's lecture, computational analysis of conventional contrasts such as T1, T2, and FLAIR provide metrics of disease processes. These markers can be calculated across thousands of surface points in the neocortex and the white matter. Importantly, they may serve as input to machine learning algorithms for the development of diagnostic markers. Machine learning is broadly divided in two groups. Supervised learning, in which systems learn from known patterns and labeled input data. Typical examples are classification tasks, which include lesion detection and prediction of clinical outcomes. The second group refers to unsupervised learning, in which machines are self-taught, meaning that they learn patterns independently. Typical examples include clustering to find disease subtypes and deep learning, which can be also used for lesion detection. Our algorithms have initially relied on morphology and intensity features derived from T1 weighted MRI. Features such as cortical thickness and sulcal depth are sampled along gray matter surfaces. Intensity features and gradients, modeling blurring, are sampled along multiple surfaces within the gray matter and the gray-white interface, and in the immediate subcortical white matter. Here are two examples of FCD lesions that were automatically detected. The lesions are outlined on MRI in green, and as you can see, they are very subtle. In fact, they were initially missed but found in the surgical specimen. In this analysis, we demonstrated class 2 diagnostic evidence for one of our algorithms, which detected MRI negative FCD lesions with 74% sensitivity. To rule out a spectrum bias, we evaluated specificity against healthy controls and clinically well-characterized disease controls, namely TLE patients with HS or hippocampal sclerosis. To minimize incorporation bias, our classifier, trained on 3 Tesla data, was tested on independent cohorts of patients and controls examined at 1.5 Tesla. Classification in this dataset yielded virtually identical results. Besides detection, another critical issue in FCD is to capture the extent of the lesion, particularly for surgical purposes. To study regions adjacent to the visible lesion, we can use methods such as geodesic distance mapping. In the graph, 0 represents the boundary of the visible lesion as manually labeled on MRI by expert observers. The vertical axis displays the feature normalized with respect to healthy controls at the same anatomical location. As you can see, cortical thickening, blurring, and intensity changes extend beyond the visible lesion and are found at the distance up to 8 millimeters in both the gray matter and the subcortical white matter. And this both in FCD type 2B with balloon cells in red and 2A characterized only by dysmorphic neurons in black. So these results underline the limits of visual inspection, not only for determining the location of FCD lesions, but also to establish the margins of lesions with respect to the surrounding tissue. Now, regarding automated FCD detection, there are some pitfalls to consider. In general, so far, all algorithms have assumed structural anomalies to be homogeneous across lesions and patients, a notion actually currently challenged by recent histopathological and genetic data. Also, they rely on limited number of features designed by human experts on the basis of their knowledge, which may not capture the full pathological complexity. Importantly, their deterministic nature does not permit risk assessment, a requirement for them to be integrated into clinical diagnostic systems. To tackle some of these limitations, we have chosen deep learning, an unsupervised machine learning technique. The key feature of deep learning is that it is self-taught. In other words, it incorporates the feature engineering step into the learning step. Deep neural networks discover hierarchical feature representations such that higher level features can be derived from lower level features. A deep neural network consists of digitized inputs which proceed through multiple layers of connected so-called neurons, each responding to different features and ultimately provides an output. Convolutional neuronal networks utilize spatial and configural information of 2D and 3D medical images. By combining linear convolutional operators, which implicitly encode spatial covariance of neighboring voxels, with nonlinearity capturing complex spatial patterns, they are expected to optimize the detection of the full FCD spectrum. This is the schematic representation of the workflow of our CNN. For each test subject, T1 weighted and flare images are first partitioned into 3D patches, which serves as an input to the CNN. Through a series of operations at different depths or layers, the CNN learns features hierarchically from the multimodal patch dataset. Finally, voxels are classified into lesional versus non-lesional. In this multi-center study involving 9 epilepsy surgery institutions around the world, we evaluate the ability of deep learning to detect MRI negative FCD. The overall sensitivity was 93% with an average of 6 false positives per patient. Performance was comparable across sites. Importantly, sensitivity in MRI negative FCD was 85%, with specificity of 89%, both in healthy and disease controls. Here you can see examples showing the detection across sites, both in adults and children. And I would like you to focus on these 5 MRI negative cases in whom lesions are very subtle and almost invisible. In 73% of patients, the FCD was among the clusters with the highest confidence. In half, it ranked the highest. These are examples of predictions and confidence in 3 MRI negative cases. In the left panels, we show the MRI of the probability maps of the predictions. The plots show the probability of the lesion in purple and false positive clusters in blue, sorted by their rank. The superimposed black line indicates the degree of confidence for each cluster. The lesion has both highest confidence, rank 1, and highest probability. On the other hand, confidence drops significantly for the other candidate clusters. The location of the FCD lesion and false positive clusters is shown on the right panels. Patient 3 illustrates the practical value of confidence. As you can see, the FCD lesion is spatially close to false positive number 3. However, confidence of this false positive cluster to be a lesion is significantly lower at about 40%. So by pairing predictions with risk stratification, the classifier may assist diagnostic hypotheses relative to other tests, thus increasing clinical confidence. From a neurobiological standpoint, recent studies have shown significant cellular variability in FCD with anomalies that may vary across lesions with the same subtype. Moreover, multiple subtypes may coexist within the same lesion. In this study, we tested the hypothesis that machine learning applied to MRI captures FCD lesional variability at a mesoscopic or millimetric scale. We studied 46 patients with histologically verified FCD type II with equal proportions of 2A and 2B and 35 healthy controls. We used the following MRI features sampled along cortical and subcortical surfaces: cortical thickness, flare intensity as a marker of gliosis, T1 over flare as a marker of myelin damage, as well as T1 and flare gradients to model gray-white matter interface blurring. We applied finally consensus clustering, an unsupervised technique based on bootstrap aggregation, to these features with the purpose to identify tissue clusters or classes with distinct profiles that collectively make up a given FCD. Clustering achieved optimal stabilities and goodness of fit at k = 4, dichotomizing lesional vertices across patients into 4 distinct classes. Results were stable across 10,000 bootstraps, supporting robustness. This is the data matrix. Columns list features and rows, lesional vertices z-scored with respect to healthy control values in healthy controls, with class membership color-coded. Line plots show mean and standard deviation of feature profiles of the 4 FCD classes. As you can see, classes have distinct patterns of anomaly. Class 1 was characterized by white matter hypomyelination and gliosis. Class 2 was driven by both gray matter and white matter anomalies. Class 3 displayed mainly gray matter gliosis and hypomyelination, and class 4 driven by blurring of the gray-white matter interface. Classes were variably expressed within and across patients. They appeared as patches within each lesion, regardless of the FCD size, as shown in these 3 examples of a large, medium, and small lesion. Class membership was replicated in 2 independent datasets supporting generalizability. Moreover, classes correlated with the degree of dyslamination, blurring, and gliosis on histology. In this study, we profiled patterns of lesional connectivity in FCD using functional MRI. Notably, a limitation to study FCD connectivity has been the fact that lesions are located anywhere across the brain, which makes it difficult to generalize findings. To overcome this challenge, we have devised a connectivity-based framework that combines resting state fMRI with cluster analysis. Let me guide you through the main steps. After subdividing the brain into 1,000 parcels, we computed for all patients and controls the connectivity of these parcels to the rest of the brain. In this matrix, the connectivity is rearranged based on the canonical networks or communities. We then choose parcels that show an overlap of more than 50% with the lesion across all patients and aggregated their connectivity profile to the rest of the brain. In essence, we go from a connectivity matrix that is irrespective of lesion location to a lesion-centered connectivity matrix. Notably, we normalize the connectivity of each lesional patch in terms of deviations from controls at anatomically analogous location. This is basically Z-scoring. High scores in red indicate hyperconnectivity, while low scores in blue indicate hypoconnectivity. We then dichotomize connectivity profiles into those belonging to the same functional community as the FCD that we call intra-community, and those belonging to other communities or inter-community. Finally, we use hierarchical clustering to identify lesional classes based on their patterns of functional connectivity. The clustering algorithm identified 3 distinct lesional classes. The connectivity strength of each class is presented in this plot. Class 1 was characterized by decreased intra- and inter-community connectivity. Class 2 was defined by a selective decrease in intra-community connectivity, while Class 3 presented with both increased intra- and inter-community connectivity. So not only FCD lesions present with structural signatures beyond those defined by neuropathology, but they also have a heterogeneous relation to whole brain networks. In fact, as demonstrated by this study, FCD lesions do not present with a predominant connectivity pattern. Rather, they are composed of areas that belong to 3 subtypes of whole brain functional embedding. So in conclusion, machine learning applied to MRI provides opportunities to optimize FCD lesion detection, understand its complex neurobiology, and design novel biomarkers. Generalizability across age, MRI hardware, and field strength makes this diagnostic decision support system ideal for widespread clinical use. And finally, MRI biotyping may help establishing genotype-phenotype associations and their clinical translation, informing personalized treatments. And with that, I would like to acknowledge the students who contribute to the work I presented, and thank you very much for your attention.